Good afternoon. I need to end the silence in this room. It's should be warm and welcoming, and we're glad you're here. I want to extend a particular welcome to all of our witnesses. Your presence and testimony are valuable, and we'll work to fulfill, as we work to fulfill our nation's promise to care for those who served. Veterans, particularly those with spinal cord injuries and disorders, are a testament to courage and resilience. The challenges they face are immense and often lifelong. For many, a new and different journey begins the moment they return home or receive their life-changing diagnosis, one marked by physical and emotional hurdles that require specialized care, innovative technology, and a dedicated support system. The VA's spinal cord injury and disorder system of care is a critical lifeline for these veterans, making certain they receive quality care when needed. During this hearing, we will examine the current state of the VA's SCID system of care, identify where the VA is succeeding, and pinpoint areas where the VA should do better. We must make certain that the access to care and benefits is timely and efficient, that the VA is at the forefront of medical research and technology, and that veterans and their caregivers have the necessary resources and support they deserve. I look forward to hearing from our witnesses this morning, I guess it's this afternoon, which include Shelly Hoover, a Navy veteran who has been living with ALS since 2013 and who will testify today using a speech generation device with eye gaze technology. Mandi Bailey, an ALS advocate who lost her Army veteran stepfather to ALS and has since dedicated her efforts to supporting veterans with ALS and their caregivers. Mary Ward, a spouse and caregiver to her Marine Corps veteran husband who has been living with ALS for 15 years. And Robert Thomas, an Army veteran and the national president of Paralyzed Veterans of America, which is the only veteran service organization dedicated to the veteran SCID community. These witnesses will provide firsthand accounts of the needs and challenges of living with spinal cord injuries and disorders, and how the VA and this committee can best support these veterans and their families. I thank you all for being here, for your service to our country, and for their continued advocacy on behalf of others. With that, I yield to the ranking member, Senator Blumenthal, for his opening remarks.
I join Senator Moran in thanking you for being here. I know that as caregivers and veterans of very deep and immediate experience with spinal cord injuries and disorders, the challenge of being here is probably even more difficult than for many of our other witnesses, and so your being here has special meaning. I'm glad we're focusing on a part of the veterans population that relies probably more than any other group on the VA, and that's a testament to the quality of the care that the VA provides. The employees who provide this kind of care are unmatched in the private sector, making these services extremely valuable, but also vulnerable to the type of cuts and cancellations that we're seeing throughout the VA. And as the VA continues to bleed employees due to this Secretary's harmful policies, the services provided to people who are directly involved in SCID are particularly at risk. So I think today's hearing is very, very timely and important. Veterans who receive these services from the VA can't easily transfer that care to community providers, where facilities are often inaccessible and providers rarely receive specialized SCID training. And the training isn't a luxury, it's essential. It's dealing with severe, life-threatening complications that can arise from seeing a provider who is not sufficiently trained. And I'm very disturbed at how Secretary Collins has failed to provide any credible assurances that he'll fight to preserve access to SCID care at the VA, which, even before these cuts, needed bolstering and expanding. The administration has left many veterans with SCID and their loved ones in limbo by failing to publish a rule to extend eligibility for participants in the Caregivers program. And I think that's an immediate need that needs to be addressed. He's been slow-rolling implementation of the Elizabeth Dole Act, which would improve access to long-term care services for veterans with SCID. He's delaying implementation of critical funding increases for organizations that serve veterans experiencing homelessness. Congress intended these funds to help providers to keep their doors open and continue supporting veterans. On both of these provisions, we were given a lot of assurances that immediate implementation was not only possible, but also a priority for the VA. We are here months later with no concrete implementation guideline for either authority. I wish we could be using today's hearing to discuss expanding SCID care at the Department of Veterans Affairs rather than just fighting to keep the status quo and asking the VA to implement laws Congress has already passed. We've approved those laws. We worked hard on them. And the VA is failing to implement them because of the leadership, not because the dedicated, hardworking VA workforce has any reluctance to do so. They want to serve. So I thank the chairman for having this hearing, and I look forward to hearing from you.
Senator Blumenthal, thank you. Ms. Hoover, you are now recognized for your testimony. Thank you. Thank you for joining us, and thank you for communicating with us.
Chairman Moran, Ranking Member Blumenthal, and distinguished members of the Senate Committee, thank you for the opportunity to appear before you today. My name is Dr. Shelly Hoover, and I am a veteran of the United States Navy. For 12 years, I have been part of the spinal cord injury and disorder system of care, and I stand here today as a testament to the life-saving care provided by the Veterans Health Administration. This testimony is the culmination of a decade spent advocating for the more than 4,000 veterans currently living with ALS. My journey with ALS began in 2013. Initially, the VA's support felt focused on end-of-life care, a system designed to manage my death rather than empower my life. But I had a different plan. I proactively sought out an ALS multidisciplinary clinic and worked to redefine my path. That experience drove me to seek a seat at the table with the VA ALS Executive Committee, ALSEC. Working alongside a team of fellow advocates, we built a relationship of trust with the ALSEC. We urged them to make the ALS system of care more user-friendly for veterans and their caregivers, and they listened. Under the visionary leadership of Drs. Ileana Howard and Cheryl Martini, the committee achieved significant improvements without any additional compensation for their work. Their dedication led to the creation of a network of ALS coordinators, including nearly all of the 170 VA medical centers. A comprehensive website to help veterans and caregivers navigate their care. An internal training program for new coordinators and other departments. This model, which integrates feedback from those with boots-on-the-ground experience, demonstrates the power of collaboration and mutual trust. It is a gold standard for enhancing the veteran experience and improving morale for VA employees who care so deeply for those they serve. Based on my lived experience, I offer 2 recommendations for continued improvement and future success. Recommendation 1: Empower stakeholders. All departments and work groups within the spinal cord injury and disorder system must develop trusting relationships with both internal and external stakeholders. As the ALSEC has demonstrated, this approach enhances employee morale, empowers stakeholders, and, most importantly, improves the quality of care and the overall experience for veterans. Recommendation 2: Ensure full funding. Congress must ensure the Veterans Health Administration is fully funded. In addition to budget cuts, congressionally allocated funds for special diagnoses, like ALS, cannot be spent due to VA-imposed hiring freezes and caps. Can that be corrected? These funding shortfalls have had a direct and devastating impact on my health and safety. I recently experienced severe complications after a VA pharmacy, due to budget cuts, was unable to provide the liquid form of a prescribed chemotherapy drug. I suffered severe burns across my chest and pelvic region, an extreme and avoidable outcome. Delays are now a constant risk. For example, my replacement mic key button, used for feeding and medications, is over a month late. How long before my current one breaks down and my stoma becomes infected? Life-sustaining breathing and nutrition supplies that were once readily available now face delays of weeks or even months. For a person with my condition, this is not just an inconvenience, it's a grave threat. I will not die from ALS, I will likely die from infection, a risk dramatically increased by these supply delays. Some may suggest that private community care is the solution, noting its budget was recently doubled. However, with one exception, my personal experience has been a disaster. I've endured 6-month delays and lost referrals, forcing my husband to spend countless hours on the phone. In one instance, a private medical office initially refused to treat me due to my tracheostomy, a clear violation of my rights. By contrast, I have never experienced a delay or faced discrimination from the Durham VA Medical Center. It is clear to me that the VA is the best choice for veterans. My family's legacy is deeply tied to military service, with 8 of my immediate family members having served in the Army, Navy, and Marines. I am profoundly grateful for the exceptional care the VA provides, and my grandchildren are thankful that I am still here because of it. To continue this gold standard of care, the spinal cord injury and disorder system must actively seek input from external stakeholders. And, above all, Congress must fully fund the VA to protect the health and lives of current and future veterans. Thank you.
Thank you. Thank you very much for your testimony and your service. I now recognize Ms. Bailey.
Hello, and thank you for the opportunity to speak before you today. My name is Mandi Bailey, and I'm the team lead for the ALS Hope Foundation's Veteran ALS Action Committee, a group of volunteers, of veterans, and caregivers that have been impacted by ALS. ALS is a 100% fatal disease with no known cure. And for reasons not yet fully understood, our veterans are at a significantly higher risk of developing ALS. My family got a crash course in ALS and VA care when my stepdad, a proud veteran, was diagnosed in 2017. Our local VA in Pensacola, Florida is under-resourced and understaffed, but they did everything they could to ensure that my stepdad was able to live his life with dignity until his passing on February 2nd, 2018. Because of the lack of services and resources at our VA, we had to use community care in addition to the services we received at the VA. In our opinion, the care we received inside the walls of our local VA medical center was far superior to the community care we received. I soon learned that we aren't alone in that opinion. In 2024, a survey was conducted by the VA's Veteran Experience Office, and that revealed the highest trust level in years. Our veterans know that by receiving care at the VA, they will be treated with the dignity and the respect that they deserve as U.S. veterans. But it wasn't always this way. The VA has worked very hard to improve the care that they provide, and the ALS system of care, much of the progress has come from allowing the stakeholders like myself to give feedback and being open to the input and ideas from the community. Dr. Ileana Howard, Director of Neurology for ALS, has done a tremendous job of listening and has made considerable improvements by doing so. She's brought the voice of the veteran to the table, and it's made an immeasurable difference. While it's important to recognize how far the VA has come in its care for veterans, we know that there's still room for growth. In 2021, the VA issued a VHA Directive 1101.07, Amyotrophic Lateral Sclerosis System of Care, and recently, a comprehensive ALS handbook. The problem is that one VA is one VA. The services and resources at one VA are not the same as the services and resources at another. For example, my team co-lead Jill Bratton's husband, Dave, received top-notch care at the Richard Raudebush VA in Indianapolis during his ALS journey. Their team was proactive, knowledgeable, and responsive to their needs. The care that Jill and Dave received is why the VA was called the gold standard in a recent report from the National Academies of Science, Engineering, and Medicine. In contrast, our care was held up by red tape, lack of knowledge, and scarce resources. Our team did what they could, and we are grateful, but there was so much we missed out on because of our zip code. Consistency of care cannot happen without proper funding and support. Veterans and their families deserve uniformly high care throughout the VA. Additionally, that same National Academies report that praised the care provided by the VA should also serve as a wake-up call. We need to fund research that will give us answers as to what is causing our military veterans to be diagnosed at higher rates and what we can do to prevent and possibly cure this disease. When you're diagnosed with ALS, you quickly learn that the treatment options are few, and the options that are there might only buy you a few months. Many times, the focus shifts to finding ways to remain engaged in life. Veterans are fortunate that the VA provides many of the tools they need to do this. Eye gaze computers, home modifications, and wheelchairs are just a few of the ways that the VA helps our veterans continue to have the best quality of life. VA providers go above and beyond to help our veterans living with ALS find ways to do things they love and are a critical part of caring for our veterans, not just for their physical health, but for their mental and emotional well-being. Veterans already carry a higher risk of suicidal ideation, but a veteran that was diagnosed with ALS, their risk goes up almost 4 times. Staying engaged in the world has a big impact on the mental health of a veteran. I've seen the impact firsthand. My dear friend and veteran living with ALS, Dr. Mary Porter, was feeling the weight of her diagnosis. Life was difficult, and she was bracing for the inevitable until she was encouraged to try her hand at art. That lifted her spirits, and she decided to see what else she could do. Fast forward to February of this year, when she not only participated in the Invictus Games, but she earned a gold medal. Now she is still active, finding new adaptive sports to try and encouraging other veterans to do the same. Protecting the services provided to our veterans can and will save lives. We strongly suggest exemptions from hiring caps for these positions funded by congressional mandated programs. I'd like to leave you with the words of Brigadier General Thomas Mikulajic from his congressional testimony on ALS in 2007. If these soldiers were dying on the field rather than at home as a result of their service, we would leave no stone unturned. We would use the best existing resources and programs to make sure they had whatever they needed to survive, to ensure that no man or woman is left behind. Thank you.
Thank you, Ms. Bailey. And now, Ms. Ward, you're recognized for your testimony.
Thank you for, did I turn that off there? Is that right?
You should see a red light, I think.
Okay.
Yes. It's confusing.
Thank you for inviting me to testify today. My name is Mary Ward, and I'm the wife and full-time caregiver for my husband, Tom.
Might pull the microphone closer to you.
Okay.
Yes, thank you.
Okay. I'm the wife and full-time caregiver for my husband, Tom, a Marine Corps veteran diagnosed with service-connected ALS over 15 years ago. I am also a 2016 Elizabeth Dole Foundation Fellow. I would like you to pause and think of a simple pleasure you enjoy. For me, it has long been a Starbucks vanilla bean frappuccino, 3 pumps of vanilla, fat-free milk, and whipped cream. For years, I thought the joy was in the ritual, but this past July, I realized I had redefined what it means to me. Now it comes when I drink that frappuccino, knowing there is a nurse at home with my veteran husband, ensuring he is safe and supported. In that moment, I am not a caregiver. I am me, doing something normal. That is the gift of respite, and it only took us 8 years to get there. To understand the importance of long-term care support, it helps to know our journey. In 2010, Tom was diagnosed with ALS, and in 2013 with type 2 diabetes. He is rated 100% permanently and totally disabled. A typical day includes helping him from his bed to his wheelchair, checking his blood glucose frequently, responding to alarms, getting him showered and dressed, administering medications, assisting him with eating, and doing cough assist to help him clear mucus from his lungs. Over the years, we have experienced numerous struggles and small victories. For example, shortly after his diagnosis, the VA denied the Specially Adaptive Housing Grant and Adaptive Vehicle Grant because Tom was not yet rated 100%. Despite having been diagnosed with a progressive terminal disease, it took 2 years before a policy change shifted that rated him to 100%. During that same period, the VA did give him a power wheelchair, but it stayed in the garage because we didn't have a handicap-accessible home or vehicle that could accommodate it. Finally, after the wheelchair was delivered, the VA approved this vehicle grant. Knowing the destructive nature of ALS, we got busy developing a plan for my future as a widow. In 2010, we moved from Durham to Wilmington to downsize and save money, and I accepted a virtual teaching position. And when I did that, I left my state retirement behind. Finally, in 2013, the VA approved Tom for the SAH grant, but that didn't mean our wait was over. From start to finish, it took 27 months to make the house accessible. It is not a process I would want to repeat. In 2016, we enrolled in the VA's home-based primary care program. However, because we no longer lived in the catchment area for Durham services, we would only have access through the Wilmington CBOC. If we chose Wilmington, we could no longer directly access the superior ALS care available at the Durham VA. We had to choose. After a series of mishaps due to the situation, including the inability to address a malfunction with Tom's non-invasive ventilator, we made the difficult choice to give up HBPC and move all care to Durham. After learning about veteran-directed care, I decided to apply for Tom. VDC is an innovative program that offers the veteran a budget for personal care services and allows more flexibility and control of his or her care. And even though I knew another veteran enrolled in the VDC through the Durham VA, I was repeatedly told by a social worker that it simply didn't exist there, and I let it go. I didn't have the energy to take on another battle while caring for Tom and dealing with his increasing health complications. I eventually tried again, but my attempts to access VDC were foiled until last year when we were enrolled. Unfortunately, this still did not mean we received any services. When I asked for a timeline regarding funding, the response was 30 days, 60 days, 90 days, I just don't know. With that lack of certainty and seemingly zero sense of urgency, we reluctantly withdrew from the program. Recently, I realized I couldn't do it alone anymore. His ALS progression was more pronounced, his diabetes grew more complex, and I didn't realize how exhausted I was from the last few years of 24/7 caregiving. Together with the Elizabeth Dole Foundation, we pursued skilled nursing care as a possible alternative. At first, I doubted Tom would qualify. He has multiple complex diagnoses, but he is not ventilator dependent, which seems to be the criteria. Finally, after the intervention of leadership, the VA approved skilled nursing care. A long time ago, someone asked Tom about me as his caregiver, and he said, "She is my wife first and caregiver second." That had insidiously changed over the last few years. The benefit of respite for me is clear, and because of it, the care I provide Tom is exponentially better. My sense of humor and joy has returned. At the end of the nurse's shift, I look forward to seeing him. Just last week, one of our nurses discovered Tom's blood pressure was running high despite medication. This finding likely prevented a crisis. I share our story because while we have finally found the proper support, it should not have taken 8 years, relentless advocacy, and national-level intervention to get here. Too many caregivers give up before they reach this point. They go unseen, unsupported, and burned out. Simply put, veterans suffer when their caregivers suffer. I hope you will note the recommendations I outlined in my written testimony, especially the need to promote effective, proactive, and comprehensive care coordination. For those with devastating injuries and illnesses, long-term care support, especially respite, is not a luxury. It is essential for caregivers, for families, and for the veterans who depend on us. I am grateful for the nurses who now come into our home, for the Elizabeth Dole Foundation's relentless advocacy, and for the VA staff who have stood by us. But the care we now receive should not be the exception reached only after years of struggle. It should be the standard. For every Frappuccino moment I now enjoy, there are thousands of caregivers still waiting for that moment to take a breath. Please make it possible for them to find joy again and to see and feel that they matter too. They're caregivers, they're veterans care, and sometimes their lives depend on it. Thank you.
Thank you, Ms. Ward. And now, Mr. Thomas, thank you.
Chairman Rand, Ranking Member Blumenthal, and members of the committee, I appreciate the opportunity to speak to you today on behalf of Paralyzed Veterans of America about the strengths and weaknesses of the VA care for veterans with spinal cord injuries or disorders, or SCID. When I testified before the committee in March, I expressed our frustration with the existing state of the SCID system and concerns about its future. We have relayed some of our biggest concerns to Secretary Collins, and he has signaled to us that the VA's specialized services and the care of catastrophically disabled veterans are a priority in this administration. But he can't do it alone. Your leadership and support are needed to preserve and strengthen the SEID system of care and all VA care for catastrophically disabled veterans. PVA firmly believes VA is the best health care provider for disabled veterans, particularly those with catastrophic disabilities. More importantly, our members consistently choose VA. Recently, a PVA member expressed this sentiment when he relayed that while he has had surgery in the community, the VA doctor he sees at the Dwight D. Eisenhower VA Medical Center in Leavenworth, Kansas, understand the full nature of his trauma, and they provide the tailored support with post-surgery rehab and long-term support that increase his quality of life. Another PVA member in Colorado shared his contrasting experience between VA and community emergency room visits following a severe flare-up of MS. VA published the story, and I strongly encourage you to read it. PVA has three primary concerns about the ability of VA's SEID system of care to continue serving veterans both now and in the future. These concerns are ongoing staffing vacancies, delayed infrastructure improvements, and the continued shortage of specialty long-term care beds. Staffing levels for the SEID system of care are detailed in VHA Directive 1176. The requirements outlined in this directive are based on the level of care needed to maintain the health and well-being of veterans with SEID. Unfortunately, VA leaders have long treated them as optional rather than a directive based on best care standards. As a result, VA can only staff a nominal number of beds in some locations. The impact of such practice is profound, causing severe delays in critically needed routine care, including annual exams and respite, as well as acute care needs. Such delays have real consequences for veterans who need care now. The VA must be able to staff to the level needed to serve veterans with SEID. We also need new approaches to recruiting medical professionals in hard-to-recruit locations. Furthermore, the bureaucratic hiring process must be streamlined to allow professionals to be identified and onboarded as quickly as possible. Secondly, we are concerned about delayed infrastructure improvements. VA's SEID system of care is comprised of 25 acute care centers and 6 long-term care centers with an average age of nearly 40 years old. Many of the older centers have only had minor cosmetic renovations. More than a dozen SEID-related construction projects on the skip list continue to go unfunded year after year. In reviewing VA infrastructure, decision makers must remember that VA's SEID system of care is unique and not replicated outside the VA. We believe VA should return to the practice of placing greater emphasis on funding facilities that support the types of services like SEID care, which the department uniquely provides. Investment in these areas will greatly strengthen VA's specialty care services and ensure their future availability. Finally, our nation's lack of adequate long-term care options is an enormous problem for people with catastrophic disabilities. There are very few long-term care facilities that are capable of appropriately serving veterans with SEID. With less than 180 beds, VA's 6 existing SEID long-term care facilities are not enough for the tens of thousands of veterans with SEID. Expanding projects providing additional beds would be a good first step to ensuring quality care. Many PVA members also depend on VA home and community-based services throughout their lives. We are very appreciative of Congress' passage last year of the Senator Elizabeth Dole Act. We need you to exercise your oversight authority to ensure the measure is implemented as Congress intended. Thank you for the opportunity to present our views this afternoon. I'll be happy to answer any questions.
Thank you, Mr. Thomas. Let me ask you just that last sentence that you indicated. Are you aware of, is the implementation far enough along of the Elizabeth Dole Act that you know of instances in where we need to be exercising our oversight authority to get something on the right track that seems to be on the wrong track?
Thank you. That's a great question. So there are some limitations to the veteran-directed care that come out through the Elizabeth Dole Act that we hear it's implemented all throughout the VA, but individual members and all that try and get on the program are not able to get on the program because it's not at their VA facility.
That's really important for us to know. The Elizabeth Dole Act, I think, is, again, one of the more and most significant pieces of legislation this committee has enacted. But implementation is hugely important, and we'll continue to work with you and PVA to make certain that that and other instances are brought to the VA's attention for correction. Make sense?
Yes, sir.
Let me ask you, Ms. Ward, caregivers, especially those for those with spinal cord injuries or disorders, as you indicated, face major physical, emotional, and financial strain. You talked about respite care programs, and they fall short. What reforms, changes would you suggest that need to be pursued to make certain that caregivers receive adequate support without compromising their own health and well-being?
Well, I think that's where I think about the coordination of care. Personally, I'm in the PCAFC program, and I accessed my caregiver support coordinator for respite care to come here today to get approval for that. And I only know that I have approval for that, that I could get approval for that because I worked with the Elizabeth Dole Foundation worked with me to get the nursing care that my husband needed. But I didn't know who to ask to get that done, and that's a problem. And I should know. We're 15 years into this disease. I should know, and believe me, I know a lot about the VA and the bureaucracy and the challenges. But there is a point at which I'm busy being a caregiver. I'm busy trying to keep this guy alive, and I can't do all that. So I need somebody at the VA who I can say, hey, I need this help. Do you understand what this program is? Can you get veteran-directed care? Can you get long-term care for us? What can we do? How can you help me do the job that I need to do?
You're actively engaged in the Elizabeth Dole Foundation. Tell me what services are offered that others ought to know about. Someone in the same position you've been in, where should they turn for help?
Well, if they're not in PCAFC, I don't have an answer for that. Okay. I don't know who they would go to. If you're in the veteran ALS lane, let's call it that, in the VA, there is an ALS coordinator at many of the VAs, and I think Mandi Bailey probably can speak to that a little bit better than me. I do not access the ALS coordinator because I actually knew more than our ALS coordinator at first, so I could do her job or I could still be Tom's caregiver. So,
well, let me ask Ms. Bailey that question. I think we recognize that the VA, let me put it this way, many veterans don't know what services they're entitled to, don't know what's available. Obviously, communication is important, but particularly for caregivers, and tell me how you think we can help provide the information necessary to get people to the resources that they need.
In my opinion, a lot of it's going to come down to funding and support. In our area, we are a very underserved, under-resourced area. So everything that we did pretty much felt like it was sent out to community care. The ALS coordinator position is a fairly new thing that has been brought about. I believe that came in with the VHA Directive 1101.07. It wasn't around when my stepdad was going through ALS. For us, it was calling our caseworker, and because of the understaffed nature of the VA where we live, sometimes it was hard to get a call back because she was busy herself taking care of the many, many, many other families and veterans that she had to contend with. So honestly, I think a lot of that's going to come down to funding and support. Our VA, last I heard, was 140% of capacity. They are wildly, wildly understaffed for what they're dealing with. They don't have the resources and time available while they are in those walls doing their job to be able to answer all those phone calls and get people connected with the resources that they need and do the research to find out where they need to be sent. So again, funding and support. Our VAs desperately need that funding and support to do their jobs the way that our veterans deserve.
With that, let me call on the ranking member.
Thank you. Again, thank you all for being here and for your excellent testimony. We've heard about community care providers outside the VA presenting accessibility challenges when SCID veterans or others who are non-ambulatory, disabled, or have complex health needs try to get access to those private non-VA facilities. I wonder if you could talk a little bit from your experience, what you've seen or heard, Ms. Bailey and others on the panel.
We were sent to the community to get our care first to see a neurologist. At that point, there was not an on-staff neurologist at our local VA. Thank goodness there are now. We have a fantastic neurologist at our local VA. Unfortunately, they weren't there for us. It did take some time to get put into the schedule to see the neurologist, and we were his first people that he had dealt with ALS. When you're dealing with ALS, you want somebody who has knowledge, not somebody who says, you know, this is the first time I've dealt with that. That was really, really difficult for us. It's scary. It's so scary. We're grateful that he was willing to learn, but the care that was in the community was nothing like the care that we received at the VA. They at least knew what ALS was, and although it was held up by red tape and all of the limitations that they had, it was still far superior to the care that we received. We even had to go out of our VA when he needed his feeding tube done. We had to go to Biloxi, which is several hours away. That's a really difficult drive when you are taking care of somebody living with ALS who can't move their arms and legs. You're the only person who's able to do that for them. And then you have to turn around and drive home the same day. I can't say that the community care in our area would have been much better. Again, lack of knowledge is a huge, huge problem. They don't understand the complex needs of ALS like the VA providers would.
Others?
Yes, in addition to what Ms. Bailey has just said, that a lot of the community facilities don't have the adequate amount of wheelchair space when you go in there, or the proper equipment to move an individual in a wheelchair over to the exam tables, or even give them a good x-ray. So that we run into that issue all the time.
I want to ask about mental health. I have a bill, it's called the BRAVE Act, which includes a provision requiring the VA to establish a pilot program to ensure VA residential rehabilitation treatment programs. These are, in effect, inpatient residential treatment, including for mental health. Maybe you can comment on the need for both inpatient and other kinds of mental health treatment programs.
As I mentioned in my testimony, when you're diagnosed with ALS as a veteran, your suicidal ideation risk goes up tremendously. Mental health, while it is addressed, typically there's a questionnaire or they're asking several questions to kind of assess how you're doing. I think there is a bigger need to address the mental health needs of veterans with spinal cord injury and disorder, especially in ALS. When you're given a terminal diagnosis, it changes your entire outlook on the world. My stepdad, wanted to take his life because it became too much for him, and he didn't, and I'm thankful for that. But I wish that there would have been more of a focus on mental health. I wish that he had had somebody like my friend Dr. Mary Porter had that would have encouraged him to try new things and to see that he could live with ALS and you're not dying of ALS. I think that's a really important thing that needs to be addressed in the mental health area for ALS.
Thank you. Any others? Thank you. Thanks, Mr. Chairman.
Senator Tillis.
Thank you, Mr. Chairman. Ms. Ward, welcome to the committee. You may not know that I'm actually sitting in the seat that was occupied by Senator Dole back in the day, and very proud of the work she continues to do in this and so many other areas. So welcome to the committee. Before I ask a few questions, first, Dr. Hoover, we're going to be submitting for the record some questions that I'd like to get from you in terms of the sort of the fabric that has to come together to provide a network and supporting people suffering from this horrible disease. And before I start there, though, I was, a couple of weeks ago, I was walking down the hallway. I grew up in a family of 6 kids, so I know how to, hear a lot of voices at once. I heard a Capitol police officer say he was going to have to file an appeal or try to figure out a way to get care himself, not in this space. But I went up to him and asked him, I said, have you contacted your congressman? He's not from North Carolina. I said, but look, I want to help you out. But make sure that you're using every available resource before you start spending money, which is why in the last Congress I proposed the Patriot Bill of Rights, which is to make absolutely certain that any veteran knows that before you spend a dime on an attorney or even other support organizations, you put a call in to your U.S. Senator, put a call into your congressman. What I wanted to do, and I've run into a little bit of pushback, mainly from people who benefit from patriots not knowing this, is to make sure before you sign an agreement with somebody who's going to act on your behalf and charge you for that fee, that you know what options are available that are not subject to a charge, like a U.S. Senator who's hell-bent on trying to clear cases before you have to go anywhere else. And that's what I do in North Carolina. So we're going to reintroduce the Patriots Bill of Rights. It's pretty straightforward. If you're going after Camp Lejeune toxics or you're trying to help somebody, I want a piece of paper down there that says these options were available to you. If you haven't used them, you may want to. Before some of the benefits that you've worked hard for and deserve go to somebody else representing on your behalf. We can't close all cases. Some of them have to be adjudicated, and there's an appropriate place. But I do think that there are some organizations out there that hope they get a good outcome for the veteran they're representing, but frankly, they also want a good outcome for their pocketbook. So in the remaining time I have here, Ms. Ward, spread the word in North Carolina. I have 473 days before I retire. And I'm not counting those days because I'm counting the days to get out of here. That's how much more time I have to help. Ms. Bailey, and to everyone, I have a personal story on caregiving. I know how hard it can be. Even that coffee break, your testimony was very compelling. I don't believe I believe everybody in the VA wants to do the right thing, but we're doing things inconsistently and we're doing things on an uninformed basis. We don't need somebody providing care to a very specific disease that has very specific protocols for trying to provide the best care. We don't want somebody doing on-the-job training, to your point, Ms. Bailey. There are good stories to be told, even in North Carolina. But the variation between facilities within our state and the variation across the country is unacceptable. I worked in management consulting for my entire career before I got into public service. There's such a thing as best practices. And what I'd like for you all to think about in your respective, from your respective organizations, let's shine some light on some best practices that are going on in the VA and then put pressure that's oftentimes a resource issue. But let's put pressure on everybody measuring up to what that best practice looks like. And let's make sure that the secretary, who I have great confidence in, and everybody in the VA, I mean, people are working hard, but it's all about resource, connections, and setting high expectations and measuring the results. And so I'm not going to ask you, any questions here in the committee, but we will be submitting some questions for the record to say, how do we do it? How do we find one in every state if there is a best practice? To say that every BISN should have a best practice model, and if they don't, we need to have one, in this case and several others. And count me in my remaining time to do everything I can to help. And in the meantime, count me in to make sure that every veteran knows if they can't even get a good response from a congressman or a senator from their state, we'll work with those senators first. We'll do the casework in North Carolina for anybody. Thank you.
Senator Tillis, thank you. You took me by surprise claiming the Dole seat because I thought, no, that's me. Wrong Dole. Senator Hassan.
Thank you very much, Mr. Chair, and I appreciate you and the ranking member having this hearing today. To our witnesses, thank you so much for testifying before us today and for your service to our country and to our veterans. Ms. Bailey, I want to start with a question for you. First, my condolences for your family's loss.
Thank you.
I didn't know your stepfather, but I'm confident that he would be proud of your advocacy for veterans. Your testimony touched upon an issue that I think is really important, which is access to high-quality care when you need it and where you need it, right? And in response to questions from Senator Blumenthal, you mentioned that after your stepfather's ALS diagnosis, he had to use community care in addition to the care he received at the VA because of the lack of resources available. And you talked about the impact, the lack of experience of that community care provider. But this is beyond an individual profile of a particular condition or disease. My concern, because I am from New Hampshire, which doesn't have a full-service VA hospital, and also has a very high rural population of veterans who live far away from the nearest VA facility. Can you just expand on how veterans are affected when they can't get all of the care that they need through a VA that is practically accessible to them?
There's a lot of things that can happen. First and foremost, I think there's kind of a mental aspect to it. At the VA, it's a culture. Our veterans like being at the VA. They prefer it because those people understand them. Many of the VA providers and employees are veterans themselves. And there's a unique bond that veterans have and that trust that they have. So I think that's a big thing right there to look at. The lack of knowledge in these conditions like ALS, that's very, very important to address. And I think that having that in our family and being sent to the community to get the care, it was frustrating. Our family questioned, should we even go back to this doctor? And that's dangerous when you're dealing with ALS. There's a lot of things that you need to consider: feeding tubes, breathing options, PT, OT, respiratory care. You need to make sure you're taking all of those things into account. And if you're sent to a community care physician or provider that doesn't really understand your condition, you're not as likely to go back and continue that care. And you have a problem with, well, is this going to go downhill a lot faster? What's this going to do? So I think that making sure, even at those VAs that aren't a full service, they are knowledgeable enough in the community to know, where should I send these people that know about ALS, that are going to treat my veterans the way they deserve to be treated, that are going to treat them like I would. So that's something to really kind of think about when we're using the community care. It is an option, and I do think that it should stay an option, but I don't think it should be our go-to option for our veterans.
I appreciate that very much, and I would just, a quick personal aside, my son has a feeding tube, and it was a neurologist who treats a whole lot of children with feeding tubes who figured out how we could get capsulated medication into the feeding tube without clogging it. She also happened to be a mother, and I happen to think that that played something into it, but it really does make a huge difference. Mrs. Ward, in your written testimony, you discussed the need to fully implement provisions of the Dole Act, which President Biden signed into law at the start of this year. And I share your concern about the delayed implementation of the bill. Now, Senator Moran asked you about oversight, But as someone who has such personal knowledge about the challenges that veterans and caregivers face, can you please tell us a little more about how full implementation of the Dole Act would support caregivers and how its continued delay might affect you, your family, and our other veterans?
Yes, thank you for the question. I think that the full implementation of the Dole Act would eliminate this sense of that all these beautiful programs that we have at the VA are not, they're so siloed, is
Right.
what it feels like. Like, how can I get home-based primary care? Because I live in an area where I'm too far from the main Durham VA. But why can't Fayetteville, which is where the Wilmington CBOC falls under,
Right.
why can't they communicate well with Durham? Why can't I have that? Why is it so hard to get veteran-directed care? I mean, we did get it. We finally got it.
Yeah.
But then we got skill care. And we're not going to use services we don't actually need right now,
Right.
just because we can get them, right? So nursing care really fits for our situation. But then what about palliative care? How do we get that? Does my PCAFC coordinator know about how to get palliative care? What about hospice? And how can we set it up so that this man that I love so much can stay at home for the rest of his life? And it shouldn't take so much work. And my sense of working with some of the people at the VA, if they want to do the right thing, we have had pretty much a good experience with everybody that we work with at the VA. But they don't know this program from that program. And my understanding of the Dole bill is that that's not there anymore. Those barriers aren't there. There's so many barriers that somebody like me, who's well-educated and experienced with the VA, I sometimes can't get access to these programs. And it's so tiring to fight them. I just want to go drink my Frappuccino somewhere. I'm not even asking for a lot. I'm not asking to go to Hawaii or to Italy or something. I just want to have a little bit of peace, and I want to be able to take care of them at home. And whether my veteran has ALS or another spinal cord injury or traumatic brain injury, it doesn't matter. We all should be able to access this care so that we can keep doing what we do. It shouldn't be siloed like it feels like.
I appreciate that. I appreciate your indulgence, Mr. Chair, with the time. Mr. Thomas, I'll submit a question for the record for you. Again, I appreciate all of you very much being here. We really value your care, your service, and your expertise. Thank you.
Thank you, Senator King.
Thank you, Mr. Chairman. Before I ask my questions, I have to acknowledge that in the last 5 years, I've lost two of my best friends to ALS. One was one of my oldest friends from high school football. And one was one of my very best friends in Maine, George Smith, who battled this disease, this awful disease, with such courage. And I can't not acknowledge these two guys that played such an important role in my life. Ms. Bailey, you said something that you just touched on it briefly that I find very potentially important, and that is that veterans seem to contract ALS at something like twice the level of the population at large. And I will ask this of our second panel, are there any theories on that? Because I've always viewed ALS as almost like being struck by lightning, but that suggests that there may be environmental causes that contribute to the contraction of this disease. Are there theories on this?
There are theories, anything from the traumatic head injury, environmental exposures when they're overseas. There's a lot of different theories, but there's nothing concrete, which is why we need to support research that's going to dig into this a little bit deeper. There have even been studies that show some specific occupations inside the military are up to 10 times as likely to be diagnosed, and that's terrifying. My husband served in the Army. My nephew just joined the Army. I want to make sure that, God forbid, if something happens to them, that they are able to get the best care possible. And the research that can come from learning more about the veteran impact, it can go a long way in the civilian population too.
I agree. I hope that's, Mr. Chairman, I think that's some research that we should really encourage. Both the VA is the likely place to conduct that research. Mr. Thomas, accessibility to long-term care. you touched on this in your testimony. My understanding is that this is one of the greatest problems facing our veteran community. Is that true?
Yes, it is. So-
And you mentioned a number, you said thousands. Do you have any idea how many SCID patients, veterans there are in round numbers?
Well, Senator, I'll have to get back to you with the exact number, but I would say somewhere around 60,000.
But it's safe to say that it grossly exceeds the availability of resources, particularly for long-term care. Is that correct?
Yes.
We've talked a bit about the Elizabeth Dole Act, and I think I'll join my colleagues and ask for you to give us your thoughts, perhaps in writing after this hearing, on how it's being implemented and not being implemented and where the gaps are. Because one of our roles here, often in our business, we pass the law and it's sort of, okay, we've done our thing, but I don't believe that. I think part of our responsibility is to oversee the implementation and execution of these laws. So it'd be very helpful to us to sort of survey your colleagues, your contacts, your circle of friends in the community to tell us how this law is working and how we can improve it and what we must do to improve it. The other thing that bothers me is Mr. Thomas, you mentioned onboarding, and unfortunately at the VA now there's a hiring freeze, and there is hiring going on in certain areas. But the VA, as of the end of this month, I think is going to be 30,000 people less than it was at the beginning of this year. Do any of you see the staffing reductions as affecting the level of care and the responsiveness of the various VA facilities with which you engage, Mr. Thomas?
So that there's been a lot of lack of staffing on the SCID centers, for a while, but, we do see that the quality of care is still trying to be maintained, but we do need those nurses. We do need that team effect to make sure that our members get the quality of care that they need.
And I think one of you mentioned burnout. I mean, we've got to maintain the good quality people that we have and not burn them out because of understaffing. Would you agree?
I agree.
And finally, Dr. Hoover, I want to commend you for being here and providing your very compelling testimony. And we will look forward to your response to some of the questions after the hearing. Thank you all. This has been very powerful testimony. And again, we can't fix problems we don't know about. So the invitation is for you to tell us what needs fixing, whether it's administrative or whether it's a matter of the law. Take advantage of the fact that you have a group of U.S. senators here who are totally committed to this issue and its amelioration and mitigation. So thank you all for your testimony. Thank you, Mr. Chairman.
Senator King, thanks for that summary, and recognize now Senator Duckworth.
Thank you, Mr. Chairman, and thank you to all the witnesses who are here today. As you know, Mr. Chairman, this committee has earned a longstanding reputation for prioritizing pragmatic bipartisanship. In my view, it is a commitment that all committees should strive to achieve. Preserving the bipartisan nature of our work is especially critical amid this administration's attacks on America's cities, and while Immigration and Customs Enforcement is actively stealing U.S. Department of Defense and U.S. Department of Veterans Affairs resources away from their core mission to support its invasion of Chicago. Specifically, at Hines VA Hospital, my VA home, where I get my care, it already suffers from limited parking that is inadequate for the level of patient demand. I think any veteran that goes to a VA hospital shares a frustration across the country of the inadequate parking. ICE has taken over 12 parking spots for operations at Hines VA that have nothing to do with providing veterans with care, and this is causing anxiety and confusion among staff and patients. Diverting VA resources for ICE's reckless paramilitary immigration enforcement operations not only does nothing to enhance veteran care, but it likely will harm care delivery. Veterans should be able to safely access their health care services without fear of intimidation, harassment, or even detainment. And it is absurd to believe that allowing ICE to operate in any capacity on any VA campus will not adversely impact delivery of care for their patients. This is especially true at Hines. The VA must establish a clear, strong policy against capitulation to ICE Veterans and their family members that receive care at VA medical facilities across our country need to be protected. Otherwise, I am deeply concerned that patients would delay or cancel their appointments due to well-documented risks that they will be aggressively accosted by an out-of-control, secretive paramilitary force and whisked away in unmarked vans solely because of the color of their skin, what they look like, race, or the language that they speak. If VA fails to stop ICE's theft of its resources, the department will validate the veteran community's worst suspicions about the Trump administration, namely that President Trump is sabotaging VA's ability to carry out its mission and actively working to manufacture a crisis that would justify privatization of the VA. Earlier this year, VA cut 80,000 jobs, including doctors and nurses. A recent ProPublica article reported on the consequences of this massive disruption, noting, and I quote, "The VA this year is down more than 600 doctors and about 1,900 nurses. The number of doctors on staff has declined each month since President Donald Trump took office. The agency also lost twice as many nurses as it hired between January and June." The VA said it is working to address this, including by referring veterans to private providers and telehealth appointments. Meanwhile, waiting times for new patients seeking primary and specialized care are increasing. And I'm gravely concerned that Trump administration's dismantling of VA's capabilities and capacity is intended to create chaos that will achieve two of their main goals. First, they want to accelerate VA dependence on private sector providers. And second, they want to degrade VA's quality of care to justify privatizing our nation's largest integrated healthcare system. Dating back to President Trump's first term, we know he is surrounded by wealthy donors who would love nothing more than to dismantle VA and force all veterans, particularly veterans who need specialized care, into the often more expensive yet less effective private sector healthcare system. After all, VA providers are trained so they can address the unique needs of veterans, and this is just not true for most non-VA providers. A non-VA provider may look at a veteran and see that they have prostate cancer, but not check them for ischemic heart disease or leukemia B, two other conditions that are tied to Agent Orange exposure, for example. Instead of siphoning resources away from the VA to a civilian health system that is already under duress due to Republicans' biggest Medicaid cut in history, we should be investing in VA civil servants while upgrading facilities and technologies to strengthen VA delivery of care. To all of the panelists, what specific steps should the VA take to ensure there are enough providers and accessible facilities for treating veterans with SCI D in a timely manner and with the dignity and respect that they deserve? Would any of you like to answer that? Do you have any steps that you think the VA should be taking to support spinal cord injury patients, also through the providing providers as well as access to facilities?
Shelly and I mentioned in our testimonies, stop any hiring freezes or hiring caps, support and fund additional positions. Those, I think, are going to be the biggest steps you can make. It's hard to serve our veterans with their hands tied behind their backs right now, and it feels like that's what a lot of them are doing.
Thank you. Thank you, Mr. Chairman.
Senator Duckworth, thank you. I don't anticipate having a second round, but having said that, I'd like to ask a couple of questions myself, unless there's concern about being left out, anybody else. I just want to capitalize on just a couple of things. First of all, community care. Is there ALS and these circumstances in which it makes sense in your minds to refer to a program, a hospital, a set of physicians that have expertise in this arena, and it makes sense for the VA to allow for referral to that community care? Ms. Ward?
Yes, I'd like to speak to that. We have an excellent ALS center at the Duke Center for ALS Care Clinic, a clinic experience for somebody with ALS. They fortunately do have clinic rooms that they are large enough to support not just somebody who's in a wheelchair, but family members to come along with them. And they stay in that room for hours. Every specialty comes to see them. Respiratory care, pulmonary, social workers come through, the ALS Association will come through, your neurologist comes through. It's an exhausting experience. It's a great experience, though, because you get soup to nuts there. But to try to get a community care referral, you have to get one for each specialty that's there, right? So that's hard work to get a community care, especially for it all to come together so that you have a referral for every specialty care, healthcare provider that comes to that room. For us personally, we use Medicare because it's easier. I mean, you know, is it the right thing to do? You know, probably not. Probably really should go through the VA to make that happen. But it's hard to do, though, too. So, I mean, I personally don't want to go through all of that.
I appreciate knowing that, and it seems to me that that's not a damning thing about referral to community care. It's a damning thing about the way we refer it to community care.
Yeah,
If we could get the
that's true.
referral fixed, that'd be an improvement, and you'd have in this instance, a level of expertise, a combination of all the services in one location that might make sense for a particular veteran or a veteran's family member. Because the standard in community care is what's in the best interest of the veteran, to be determined by the veteran and his or her provider. And in some instances, there may be a program, as I say, a facility, a set of doctors, a continuum of care that might make sense. And I want to make sure that if that's the case, best interest, that that's a possibility. Mr. Thomas, let me conclude my questions with just a follow-up to something that's been said in response to my colleagues' questions. The issue of the Access Act, one of the things that occurred, and the PVA supports the Access Act, but one of the reasons that's true is because we addressed the concerns regarding the VA's referrals to community providers who are ill-equipped. We heard testimony today about we heard testimony about this being a new thing to a neurologist, not treating an ALS patient. And the PVA advocated for provisions in the Access Act to address this issue of referrals to people who are ill-equipped to handle the referral. Is that true? And you have anything to say about that?
So I would say that is true. And, you know, it is hard to get, when you get a referral and go out there into the community, as was stated, that, you know, individuals need to be able to choose who they want to choose. And we understand that, and we are on board and agree with that. But we need to be referred to doctors that truly understand the aspect of what SCID entails on the body. And a lot of times when we're referred out there to the community, they don't understand that. So that's why most of our members choose the VA.
That makes sense to me, but I do want to highlight, at least my understanding, the Access Act includes language that veteran organizations, and I think including the PVA, encouraged to be included in the Access Act that deals with the concerns about referrals to someone who shouldn't be referred to because it's a new experience for them, that's new field for them, same field, I guess, a different kind of patient and a different kind of circumstance. And we want to make sure that the referral is actually to a provider that provides the expertise and experience that actually helpful to the veteran. So we'll continue to work on that, but I think that is part of our efforts in this Access Act to improve that circumstance. I thank you all very much. Senator King summed it up very well. Thank you for being such advocates. Thank you. I recognize that in instances here, it's very difficult for you to be away, difficult to be here, and we're grateful that you take the time. It demonstrates that you care about your loved ones, you care about people you don't even know because you want the system to work, want the VA to work, and the process to care for those who served our country, and we're all grateful for that, and I thank you for your presence. We're going to call up the second panel in just a moment. Thank you all for being here. Let me call to the table the second panel. Testifying today, this afternoon, and almost this evening on the second panel is Dr. Erica Scavella, and she's the Assistant Undersecretary for Health and Clinical Services at the U.S. Department of Veterans Affairs. I'm going to use my prerogative and ask you to introduce who you are accompanied by.
Thank you.
If you would do that, thank you, Doctor.
Yes, sir. Thank you so much. Good afternoon, Chairman Moran, Ranking Member Blumenthal, and members of the committee. Thank you for the opportunity to testify today. Joining me today is Dr. Manosha Wickremasinghe. She's Executive Director of VA Spinal Cord Injuries and Disorders System of Care. Together, our mission is to address not just the immediate needs, but also the long-term challenges and opportunities facing the veteran community affected by spinal cord injuries and disorders, also known as SCID. As we recognize the unique and evolving needs of veterans living with SCID, our response continues to center on specialized comprehensive care. These complex conditions require individualized approaches, and our commitment is to leverage the full depth of VA resources and compassionate expertise to optimize the quality of life for all veterans. VA's SCID system of care is the nation's largest, most comprehensive integrated healthcare system dedicated to treating individuals with spinal cord injuries and disorders. Our hub and spoke system enhances health, well-being, functionality, and quality of life for over 24,000 veterans. The veteran is central to all that we do, and we strive to provide care that considers the whole person. We work as interdisciplinary teams to provide acute rehabilitation, specialized medical management, primary and preventative care, respite care, and long-term support. Annual comprehensive evaluations focus on health promotion, complication prevention, and early intervention, addressing the evolving needs related to SCID at any age. To support veterans and their communities, our SCID system of care includes the SCID Home Care Program. Members of interdisciplinary teams are available to support the transition and healthcare needs of veterans with SCID in the home or community. In addition to the SCID Home Care Program, the VA SCID system of care leverages home and community-based services such as skilled home health care, homemaker home health aid, and veteran-directed care to ensure eligible veterans receive care comfortably within their home or the community. Recent legislative progress has enabled VA to expand support for veterans facing complex medical conditions. For example, Section 120 of the Senator Elizabeth Dole 21st Century Veterans Healthcare and Benefits Improvement Act raises the maximum per veteran expenditure cap for home and community-based services from 65% to 100% of community living center costs, while allowing exceptions for diagnoses such as SCID. These changes directly translate into expanded options for home-based care and greater financial flexibility. As the Vietnam-era veteran cohort continues to age, the complexity of their needs increases. In response, VA is working to expand SCID long-term care capacity with 2 funded construction projects in North Texas, which is Dallas, and the VA San Diego healthcare system. Both have had existing SCID acute and sustaining centers. Once completed, this will bring the total number of VA SCID long-term care centers to 8. Ensuring the availability of high-quality long-term care for veterans with SCID is a prominent challenge and one that remains central to our resolution, our resource allocation, and planning. Removing barriers for veterans with SCID requires ongoing investments in adaptive equipment and technology. In fiscal year 2024, VA processed more than 5,000 claims for vehicle conversions, hand controls, and entry-exit ramps, empowering safe and independent mobility for eligible veterans with service-connected disabilities. Additionally, VA's SCID system of care and Office of Advanced Manufacturing have partnered to ensure veterans have access to cutting-edge manufacturing technologies such as 3D printing and healthcare. These technologies allow for the faster innovation and improved access to personalized healthcare solutions for veterans. VA's SCID system of care maintains a strong tradition of continuous quality improvement and performance measurement. Recent initiatives have modernized outcome measurement and reporting. For example, VA has developed standardized documentation for the functional mobility assessment. This measure allows VA to evaluate veterans' satisfaction with wheeled mobility access. Chairman Moran, Ranking Member Blumenthal, this concludes my testimony. VA's SCID system of care is committed to delivering high-quality care, ensuring veterans receive the care and support they deserve. My colleague and I are prepared to answer your questions.
Thank you very much. I'm going to call on Senator King to begin the questioning.
Thank you, Mr. Chairman. I appreciate the courtesy. I want to thank both of you for being here. I hope you listened. There was a lot of praise for the VA in the last panel. There were some questions, but I think the consensus was that the veterans that have these SDID afflictions prefer the VA treatment system, and I hope you'll take that back to your colleagues. I do want to follow up on the comment that Ms. Bailey made about ALS affecting veterans in a greater proportion than in the general population. I hope that's something that will provoke some serious research. It strikes me that could be a very promising area of research, and also if something's dangerous for our veterans, we should know it. Dr. Scavella, is that something you're planning to pursue?
Yeah, thank you for that question. We are aware of the increased propensity of veterans to develop ALS, and that is included in our ongoing research to determine both presumed and causative agents. We have some suspicions and some thoughts on that, and there's ongoing research into that. But we do know that there is a correlation between having served and developing ALS. That is something that is in the literature, something that our Office of Research and Develop is looking
I hope
at.
that's pursued on an urgent basis. That could have enormous benefits if we can nail down a possible cause. That would be a huge breakthrough for thousands and thousands of people. Second question, and I apologize having to leave. I've got an appointment in my office that's already been waiting for me. Last fall, the VA indicated an interest in falls prevention, which of course contributes to these kinds of spinal cord injuries as well as traumatic brain injuries. You were going to establish, I heard, a falls prevention program. Is that, I haven't heard much lately, is that still in the works? I certainly hope it is.
So thank you for that question, Senator King. Falls prevention, I've been a clinician with VA since 1999. Falls prevention has been an ongoing effort. There may be some renewed attention to that. We want to make sure that veterans are not falling both in our facilities and in their homes. So that is something that is ongoing. I'd be happy to take that back for the record to get you details on anything that's new that's being done.
I'd appreciate that. 1 out of 4 people over 65 suffer a serious fall. It costs the economy $80 billion a year, 2/3 of which comes from Medicare. So this strikes me as low-hanging fruit in terms of healthcare cost, let alone the trauma to families and individuals that are afflicted by, as I say, traumatic brain injury, spinal injuries, and others. So I hope you will take that back and let's up the emphasis.
Thank you.
And Ms. Wickremasinghe, how'd I do?
Very well.
Pretty well.
You're more courageous than I was.
I noticed, Mr. Chairman, I didn't want to call attention to that, but you heard the testimony, and please describe the strategy for dealing with these serious injuries, SCID afflictions.
Thank you for that question, Senator. As mentioned before, the VA SCID system of care has 25 dedicated SCID centers and over 120 spoke sites. These are located within facilities which don't have our SCID centers. These spoke sites provide local primary care and SCID-informed care. Within our centers, we have large interdisciplinary teams that manage the complex care needs of our veterans, ranging from acute rehabilitation to ongoing care of secondary medical complications. We provide respite care. We have outpatient clinics. We have dedicated SCID home care programs, and we have dedicated SCID long-term care centers unique to VA.
Thank you very much, and I appreciate the outline and appreciate the work that you're doing, and I hope you were taking notes during the prior testimony. There are places where we can shore up the system. Thank you very much, Mr. Chairman. I appreciate the courtesy.
You're welcome, Senator King. Dr. Scavella, you heard, to follow up on Senator King's closing comment, you heard the testimony that occurred just moments ago. What's your takeaway? We heard correctly that there's lots of praise and appreciation for the VA and its capabilities of dealing with veterans and their caregivers. But what did you learn that you and the VA should be doing different or better? And was there something that you want to highlight for this committee that we ought to be doing to help you accomplish that?
So thank you for that question, Chairman Moran. I will say that we are very proud that we are partnering with each of the folks on your first panel. We worked extensively with Dr. Hoover to improve the care that's being provided for patients with ALS based upon her direct input. She, in her testimony, did name one of the two physicians that we were able to assign to assist with ensuring that her voice and other voices are known. Mrs. Ward, Ms. Bailey, and Mr. Thomas also talked about the extensive partnership that we have had. So I'm very pleased to hear their testimony today, and we look forward to continuing to work with them to learn about what's not working, what we can improve upon, and anything new that comes up as healthcare evolves and innovates and improves.
Well, let me raise a couple of topics then. The Congress, Dr. Scavella, has allocated the full amount of funding that the VA has requested for medical services. Has there been any hindrance in making certain that SCID systems of care receive the necessary funding to provide the complex level care needed for these veterans? In other words, the VA asked Congress in their budget for this amount of money. We've appropriated this amount of money. The VA has that. Is it getting to the care and treatment programs, the care programs for these veterans that were described today?
Yeah, thank you for that question. We are not aware of any challenges. I know that there was focus in the previous panel about staffing. It has been made clear, and we've communicated it, that we have an exemption for the caregivers that are providing direct patient care in our system. That includes our clinicians, our nurses, our physicians. That includes our social workers. That also includes those folks that make sure that the space is clean and safe for veterans to receive care. So in my understanding, we have adequate funding and are able to use those funds appropriately. When looking at our staffing from September of 2025 and comparing it to a year ago, it appears as if we have the same exact number of staff assigned to spinal cord injury and disorders. Where there may be some differences perhaps are with the differences in the categories, and we'd be happy to take that back to make sure that we are still meeting the intent.
It has, it's been brought to our attention that at least in a commentary, I would say is the way that I would describe this, that the VA spinal cord injury and disorder system is understaffed, and it's the challenge of hiring and retaining highly skilled providers, particularly in rural areas. I think you just testified that the same amount of staff in this arena within the VA, it's the same as it was a year ago. Are there differences of the different challenges depending upon where those programs are located or where the veteran resides and needs care?
Yeah, so I'll highlight that a bit. We know that there can be some challenges, but with healthcare in general, not just within VA, for both attracting, recruiting, and retaining the talent that we need to provide this skilled care. We do have a number of modalities I'll let Dr. Wickremasinghe outline related to how we can address those care needs in a rural setting.
Thank you very much. Doctor?
Thank you very much for the question, Mr. Chairman. You know, we recognize that providing care to our veterans located in rural areas is critical. We rely on transportation and telehealth in addition to our spoke clinics, which really enhance our outreach. Our spoke clinics are located in areas closest to where our veterans live many times. And that, in combination with telehealth and transportation, really, you know, are where, for us, the money is, you know, when trying to reach our rural veterans. So for example, with telehealth, we have the VA Eastern Colorado healthcare system that has expanded rural healthcare to VA Black Hills healthcare system. So we have SCID specialists who can participate in appointments with veterans who are served at Fort Meade in South Dakota. So this is occurring in many VAs. In addition, we have telemental health. We have dedicated mental health providers within our interdisciplinary teams within our centers. So we have psychologists specialized in the care of veterans with SCID participating through telemental health to reach our veterans. A third example would be our telewound programs. Our veterans with spinal cord injuries many times have skin conditions resulting in pressure injuries. And instead of having our veterans drive in for follow-up appointments, we are able to use 3D imaging and cameras to see the wounds in real time and have our clinicians monitor progress. Sometimes it also allows us to bring our veterans into our centers sooner than later when we see any changes in wounds.
Thank you. I'm going to ask another question and turn to Senator Blumenthal. And I'll continue with you, Doctor. How does the VA, we heard the circumstance described by our first panel about lack of knowledge of programs, where to go, and then the silos within the VA that make continuum of care a challenge, or the length of the necessary components of care to be coordinated. What would you tell me about that, whether it's a problem, a challenge, how's it being addressed? What would you tell the first panel about that circumstance?
Thank you for that question. I'm not able to speak for the ALS system of care. Within the SCID system of care, however, we provide an interdisciplinary, comprehensive, lifelong continuum that I mentioned earlier with our senator. And I can take that back for the record and get that information to you through the subject matter experts.
What does the VA do to educate and help connect veterans with opportunities to participate in clinical research trials?
VA is a nation's leader in healthcare research, Senator, and we currently have about 27 VA-funded trials and projects focused on veterans with spinal cord injuries and disorders. We have, for example, the Rehabilitation Research and Development Gordon Mansfield Spinal Cord Consortium located in California, works with many VAs and the UCLA branches to focus on stem cell research. We also, for example, in West Haven, Connecticut, we have a rehabilitation research and development center focused on addressing neuropathic or nerve pain, the chronic pain that affects many veterans with SCID. And so on and so forth. I could provide you much more detailed information for the record as well.
Thank you. Let me turn to Senator Blumenthal.
Thank you. Thank you both for your service. Let me ask you, how have the cuts in numbers of workforce affected the work that you do? What number have you lost?
Thank you for that question, Ranking Member Blumenthal. I don't actually have the current data on our attrition rates. I can tell you and reassure you that within our patient care, direct patient care, that there are exemptions in place to make sure that we are not affecting the ability to provide care in our facilities.
So you have been affected, or not? I'm not sure I understand your answer.
I am not aware of any effects related to staffing in the
Have
direct
you
patient
lost
care.
staff?
I'm sure that we have lost staff and gained
Lost
staff.
but you don't know how many?
I don't have that data in front of me to provide you with an accurate number, but we'd be happy to take it back for the
Do
record.
you have an estimate?
I don't have an estimate, sir.
I have no idea.
I've heard numbers bandied about, but I'd rather not give a number that is inaccurate in front of this committee.
Well, I have to say, you know, I'm disappointed that you don't have at least an estimate, given that you were responsible for this whole department. Do you have an estimate, Dr. Wickremasinghe?
Thank you for the question. I would have to take that back for the record. I do not have the data on hand.
How many nurse vacancies in SCID are there right now? How many nurse vacancies?
We don't have that data, sir.
I'm stunned. You don't have an answer? How many vacancies there are?
We'd be happy to take that back for the record. I don't have that data in front of me. I don't want to give you an inaccurate number.
How many recreational therapist vacancies are there?
I don't have that data in front of me, sir.
How many doctor vacancies?
I don't have any data related to whether we are actually above or below the recommended staffing for any of the specialties.
More vacancies now for nurses?
I don't have that.
In January of this year?
I do not have that data in front of me, sir.
Well, let me posit, let me assume that staff are necessary to deliver services, correct?
Correct.
So the number of staff would seem to be related to the quality of your service, correct?
So perhaps I can explain a bit. We have over 400,000 employees in Veterans Administration, the Department of Veterans Affairs. I don't have data on those fluctuations.
I'm dealing with SCID. I'm not talking about the whole Veterans Administration. I'm talking about dealing with those issues.
So as I testified a few minutes ago, it appears as if our staffing within SCID remains flat compared between September 2025 and September 2024. I don't have information about potential fluctuations in the types of staff that may have composed that number. So
you don't do a kind of monthly or quarterly assessment of what the recommended numbers are and how close you are to those numbers? You don't do a monthly report or any regular reporting?
We do monitor our staffing. I don't have that data in front of me today. I just had the flat number in that SCID system.
What I'm asking you to do is to provide me those numbers, vacancies for SCID nurses, recreational therapists, doctors, and other staff, month by month. to the present since over the past year?
Thank you for that. We'll do that, sir. Thank you.
When do you think you can have it?
I think we need to confer to make sure we've got the data available and how soon that will be. I'm not sure what the normal turnaround will be, but we will commit to getting that information back to you.
Did you discuss with anyone at the VA the possibility that you'd be asked about these numbers?
Again, I had focused on the total numbers within the system. I did not focus on the breakdown.
But did you talk to anybody at the VA in preparing to come here today about questions relating to staffing?
Correct, and that's why I had that number of being the same as September 2024 and September 2025.
You wouldn't say that you shouldn't have the most current numbers on vacancies.
Nobody gave me that instruction, sir.
Are people still leaving the VA in your department?
So again, I speak for thousands of employees that don't just include SCID. So there is attrition and there's recruitment. So there's fluctuation every day in our staffing.
Are you hiring?
We are hiring.
Are you hiring more than you're losing?
Again, I don't have those gains and losses data in front of me, sir.
How about cancellation of contracts? Do you have contracts with companies outside the VA?
I'm going to defer to Dr. Wickremasinghe about any contracts related to SCID.
Thank you for the question. At the national level, we don't have contracts affecting our SCID system of care, but I can't speak for each of our facilities, so I would need to take that back for the record, please.
How about the hubs and centers? They have contracts, right?
I don't want to misspeak, so I would need to take that back for the record to find out more.
You don't know whether the hubs, do the hubs and centers report to you?
At the national level, I oversee policy and the more detailed operational involvement, including contracts. Many times is at the local level, at the facility level, and some of those contracts are national contracts as well, but I don't have that information. I would need to take that back for the record to make sure that we're providing the most accurate information.
Well, my understanding is that you provide services through hubs around the country, correct? There are about 25 of them, or centers around the country, hubs and spokes?
Yes, that's correct. We have 25 dedicated SCID centers, which are in our VA medical centers.
And do they have contracts with private entities?
I am not able to answer that question because that is not something that I am directly tracking or involved with, so I would need to take that back for the record.
Well, I'm perplexed. You are in charge of policy, which means meeting basic needs of individuals served by those 25 SCID centers, and you're saying you don't know whether they have contracts with service providers outside of their entities, and you don't know whether at the national level there are contracts?
That is correct, Senator, because contracts don't fall directly under my office. We have...
You would know, you've got a center. What's the nearest one to Connecticut? Boston?
Yes.
Okay, so you would know in Boston we have a certain kind of rehabilitation service that's provided by a contractor.
For example, in Boston, we have an SCID center, and that center operates under the national guidelines and standards set forward by VA. We have Directive 1176-2, which provides the standards for care of veterans with spinal cord injuries and disorders.
All right, well, I hope maybe you can provide some more information. I have been unhappy with the delays in implementing the Dole Act, as I expressed earlier. I've repeated those concerns. The VA touts its implementation of the Dole Act as a success. Do you regard it as a success?
Thank you for that question. We are happy to have the provisions set forth in the Dole Act, which will address several concerns that were raised here during this particular hearing. We are grateful for Section 120, which will help us with some very challenging situations that our patients have been facing. So we are happy for the provision.
Don't you need more people to implement it properly and successfully?
I can't comment on needing more staff if I don't know what the current staffing is capable of providing. So again, I'd like to get back to you with the accuracy of what has been implemented, how it's been implemented, as well as whether or not we do have any staffing challenges within the fact that we appear to have a flat staffing.
What I'm hearing you say to me is you don't know whether you have enough staff to implement it successfully.
That is not what I meant to say, sir. What I'm saying is that I would like to make sure that as I'm answering a question about a new provision in legislation that we are currently implementing,
So you're not prepared to answer.
Correct. I want to make sure that I'm providing accurate information pertaining to the new legislation.
Your opinion, doctor?
Thank you for the question, Senator. What I know is that VA is pursuing value-based care to address the Elizabeth Dole Act.
I'm going to finish my questions at this point. You know, it is not a failing to say we would like to have more staff. The reason I'm asking these questions is the VA has lost thousands of dedicated, hardworking members of its workforce. And my educated guess is that that has happened in your department and that it has affected performance. And it's not your fault. It's not your fault. It's the result of decisions made by Elon Musk, Doge, tech bros, Secretary Collins, and the Trump administration that has taken a chainsaw. It's the chainsaw that Elon Musk touted as he paraded on that stage. And it has affected your workers, but even more so the brave veterans who are struggling with ALS and other spinal cord injuries. And that's a tragedy for our country. So I hope maybe you can provide more information to me because it will enable us to do better oversight. Thank you, Mr. Chairman.
Thank you, Senator Blumenthal. There are no other questions, and therefore I want to again thank our witnesses from the first panel and now from the second for their testimony, and our committee members in the audience for being here this afternoon. The hearing record will remain open for 5 legislative days should any committee members want to submit additional statements for the record. And I ask our witnesses to respond to any questions that are provided for the record that once they're received, that they are answered in a timely manner. I would ask, I think we're done. We'll adjourn the meeting, and thank you very much.